To the left, you're going to see a couple of different resources. There's the CANS training website for those who want to get Rater certified, or to the right. Looks like to my left, I apologize. And then there's also the Parade Foundation website. And through the Parade Foundation as well, for those who are interested, again, we're going to shamelessly plug our CANS conference, which is coming up in 2 weeks, and Angela and I will be presenting there along with John Pavlov. And then I put both of our emails there as well, so if there's any questions, or now that we're getting training scheduled, if you want to get a training scheduled for your region, feel free to reach out to us. Why should I do the CANS? This is a question I get quite a bit. Well, why? Why should I do it? I don't know if this is something I want to do or if this is something I need to do. Essentially, it's a clear format for identifying strengths and needs, especially for those folks in wraparound. It really helps ensure that strengths-based planning. It also ensures that safety needs are getting met and that there are things that are being addressed in care planning that are essential. It's also best practices. It's an evidence-based practice, and it's important to continue to follow and guide those. And then additionally, it's a good supervision tool, and it's a great outcome measure. So that's what we're really hoping that people will take away from the CANS, is not only can you use it to look at your youth and how your youth are doing at a present time, but you can also use it for supervision and for outcomes. And Angela, I'll let you speak a little bit to the box.
So I think we're going to get more into the CCO contract changes in a few slides. The only place right now that CANS is mandated or contractually required is that the CCOs and mental health providers are helping out child welfare and creating a partnership where the CANS is utilized to assist in care planning for care. So the changes aren't effective until January 1, and that will then bring wraparound into the fold. Do we have more in next slide? Yep. So the goal, I feel like it's a long-term goal because we're really probably going to get there more in 2017. I'd love to do everything now, but where we're working towards is CANS being the one tool across Oregon's child and youth system that's going to guide our work, provide us outcome data, ensure that we're all speaking the same language and communicating well and meeting the needs of children and families. So if you're hearing talk about CANS replacing BRRS right now and CANS being used across the intensive service array or intensive community treatment services, that is the goal, but we will not be there in January 2016. So we want to eliminate burdensome tools or things that are just duplicating work, and we want to just have one data entry portal for all of that information. So that's where we're headed, and what's going to allow us to do that is the eCAN system, which we're currently in conversation with the Parade Foundation about and Dr. Lyons. So we're not going to make huge changes in the system until we can ensure that we have that system available and set up to meet the needs of Oregon, our providers, and our CCOs. Are there any questions on that piece? So for eCANS, right now I'm working at the state level with a division called Oregon Information Systems. That entity needs to approve any IT work that we do at the state. So once I have approval from them to move forward, I'll then begin the contracting process with Dr. Lyons, which will allow us to launch into development of eCANS, which is a reporting and analytics system that's proprietary to Chapin Hill or the Parade Foundation and will allow us to provide providers and CCOs, Oregon Health Authority, everyone with immediate data that's coming out of CANS items used with youth. And that's not an immediate process. That's going to take an IT build. It's going to take some work with Dr. Lyons to make sure that we're meeting the needs of Oregon. So we're probably looking at 2017 before that project is complete.
Does anybody have any specific questions around eCANS or need any additional updates?
Anything coming in from text? Okay.
Been pretty quiet. All right, so I wanted to speak to the training process again. I think it was maybe a little bit unclear the last time, so I tried to spell it out a little bit better this time and kind of discuss specifically what the process is that we're envisioning right now. So Angela and I came together to kind of come up with this. Basically, this is our recommended training process. It's not a mandate. It's not something that we're forcing people to do or saying you have to do it, but it is what we're recommending in terms of aligning with best practices and ensuring that the people administering the CANs and using the CANs and wraparound, that it is aligned with best practices and the training and coaching is available. So our process at this time is we're going to start with FAQs and just contact us. Contact myself, contact Angela, let us know where you're at and what your needs are. The second, do we have a question?
I think.
Deanne Carr has a question. Her question is, you stated that January 1st will bring wraparound into the fold for needing to do the CANs. Some counties, CCOs, did not receive wraparound funding. How will the standards be different for funded and non-funded counties?
Great question. So for the non-funded counties, as you know, in Deschutes, you will be getting the training and technical assistance for wraparound. And ultimately, it's going to be your decision how you roll all of that out. And if you are able to achieve Oregon best practices, which will be of CANs. So Brooke and I will be working with each of those counties that are in your situation and, regions, CCOs, to figure out what's best. But I do understand that the funding may hinder some of this, but we do find that the use of CANs does not add any cost to the system and actually probably be beneficial in the regions that do want to bring on wraparound. And again, you'll be getting the training, technical assistance, same as all other regions across the state.
Lori Holmes asked what will be required instead of CASI and SC for ISA referral /ECSII.
So the CASI and XC is coming out of the 2016 CCO contract. So that will not be a required item to determine level of care and service provision for use in the state any longer. There's going to be a gap in time because we are looking at eventually having the CANs help us out in terms of level of care determination. Again, that requires the use of CANs. It requires an algorithm to be set up to assist our system with that. So Lori, right now, there won't be anything to replace CASI and XC. We want to really look at targeting the true needs of youth and families, and I think we can all agree that the CASI and XC are pretty subjective tools, and we're moving away from that, and so that'll come out of the requirement for entry into ICTS, residential treatment, all those pieces. And again, a CCO could make their own decision to continue the use of those tools, but the Oregon Health Authority will not be requiring them any longer.
Does anybody have any additional questions?
Okay, getting back into the training process again, this is a recommended process. This is not something that, but we really want to make that available so that those who are doing the CANs have that support with it, and so that you have the potential to get training and coaching as needed. So contact us if you need training or your region needs training. Email me, email Angela, and let us know what's going on. So this is our process, and I'll get into the trainings a little bit more in detail in a moment, but it's basically we'll start with the FAQs and then contact myself or Angela. And then CANS 101 training we're recommending comes prior to rater certification, and then following that would be the CANS 102 or CANS training for supervisors, and then following that, ongoing coaching and monthly webinars. So essentially what the CANS 101 is really going to look at is it's going to be an overview of CANS, the history and development. It's going to examine the rating system and an in-depth analysis of the different ratings. So it'll allow people to come into this training and really understand how to rate specific items. There will be a lot of practical examples. That was something that was specifically asked for. And my hope with this specific training is that essentially once it's given, the care coordinators, or family partners, or whoever's in the training can go out and pass the rater certification. So that's kind of the goal with CANS 101. One of the questions that we've been getting asked a lot is about continuing education units. I do believe that we will be able to offer those. We're submitting the paperwork as we speak, and I think we can offer CEUs for that particular course. The CANS 101 is the first training to roll out. We already have 2 regions that are scheduled right now, and I have a couple of dates, I believe, left for through the end of this year. But this is the only one that's currently rolling out, and that starts next month. The CANS 102 training is much more specific to CANS and wraparound. This especially would be a great one for family partners, youth partners, for wraparound teams to sit in and be a part of. It's going to take what we teach in the 4-day trainings, but go much more in depth. It's going to incorporate CANS items into care planning, safety plans, and crisis plans. And there's going to be templates for those things that care coordinators can learn from and practice with. We're working closely with OFSN and Youth Move to really make sure that we're practicing best ways to approach a youth and a family with CANS. How do we approach a family? How do we approach a foster parent with this? You know, that's been something that we've come across a lot. So it's really going to be that kind of time for the wraparound folks to sit down and really get a better understanding of how CANS can really influence their work. There's going to be a lot of practicing. There's already new scenarios that are being done and typed up, and this training is going to be about a 2-day training. So we are looking at being able to offer CEUs for this training as well, and this particular one, CANS 102, is going to start in January 2016. I do have a couple of dates that have been set up for that right now, but nobody has been scheduled yet. So let me know, or feel free to contact me if anybody wants to be scheduled for that particular training. The last piece of training that we're hoping to offer is CANS for Supervisors, and it'll essentially examine tools for the CANS in clinical supervision. So it'll show different ways that the CANS can be utilized in caseload management, outcomes, all kinds of different ways. The CANS for Supervisors, this is going to take a little while to roll out. This is the last one, so the expected rollout date for this will be spring 2016. But the hope is to have, this will be maybe a half-day or a full-day training just specifically for supervisors to look at the different applications for the CANS within clinical practice. This is another question we've been getting very frequently, so I wanted to make sure that I speak to this. Who should attend these trainings? Essentially, anyone who will be administering the CANS is recommended that they go through at least the CANS 101 training prior to rater certification. All wraparound care coordinators should go through this training, especially as CANS gets more infused into the wraparound process. It's really important for the care coordinators to go through that. We do encourage youth and family partners to get rater certified as well, especially for those sitting on wraparound teams. Youth and family partners see things with a different lens, and it's really important to make sure that their perspective is captured within the CANS. Part of what's so great about the CANS is the fact that it does capture so many different perspectives when you're looking at the ratings. And interestingly, youth and family partners have a much higher first-time passage rate for rater certification than care coordinators do, because it's not a clinical tool, and I think sometimes looking at it in that clinical lens can skew it a little bit. So youth and family partners do tend to do very well for rater certification, and we do encourage them to be a part of this. And as I said previously, we have been working with OFSN and Youth Move both on the trainings and on best practices, and so hopefully they'll be an active part of this as well going forward. Any supervisor of care coordinators, it's really critical that supervisors go through both the CANS 101 and the CANS 102, and eventually the CANS for Supervisors, because it's really going to allow them to supervise in a more effective way and to support with caseload management. Ultimately, we're hoping that mental health and other direct service providers will go through this training as well. And again, the training is specific to region and specific to need. So the way that I've been doing it right now is scheduling by region. So if somebody needs a specific training, just contact me and I'll look at getting that stuff scheduled. Other than that, there will be a lot of additional training opportunities. We are going to be doing the monthly webinars, third Monday of every month. I think the hope with this is ultimately that people can call in with technical questions around rating, that we can use this as an open kind of Q&A forum to really go over what's going on with the CANS. How is it working for you in practice? What are your needs around this? So that's kind of the hope eventually, is that this will be a forum for technical support available for those who need it. Monthly coaching and consultation following trainings with PSU will be available as needed, and again, that's something that you'll have to get scheduled with me. And at this time, there's only a couple of regions that are ready, that are going through the trainings, and they have training scheduled, so it'll be on an individualized basis. And then we're also going to be here to support with CANS implementation and strategic planning related to CANS as needed going forward. I know that's something that's also been asked about quite frequently, so those are supports that we will be able to provide. I'll turn it over to you, Angela, for this one.
Okay. So, as most of you know, Department of Human Services Child Welfare has been using the CANS for years now. And I think as wraparound comes on board and our mental health providers, it's always good to just understand the history and how we're going to work together across systems. So right now, and I was speaking to this a little bit earlier, the requirement is that within the first 60 days of youth coming into DHS custody, they do receive a CANS. And that is being provided through the CCO system now, so they're subcontracting to their mental health providers to ensure that we meet that requirement. That's directly aligned with the mental health assessment metric for CCOs. We use the exact same timeline because the vision would be that the mental health assessment and the CANS are done in partnership and together, and that all come together to provide a good plan for youth and families and foster parents and to meet the needs of that youth. And then, Tom, do you want to briefly just say how then the outcomes of the CANS determine level of care within the child welfare system on that second bullet point there? Let's hope we can hear.
Who's unmuted?
Tom? Okay, so I'll answer that. So depending on how the CANS items are scored, that does then go into a supervision plan and determination about reimbursement for foster families. And that happens at the state child welfare level. There's nothing that a mental health provider or trainer can do to determine the outcomes of how all of that's determined. So Tom has a team at state level child welfare that looks at the outcome of the CANS, and they have their own algorithm, and a lot of things go into how all that's determined. So that's not something that mental health providers or CCOs really have a part of. You know, we really, with CCOs and mental health providers, and within wraparound, we want to utilize the CANS to assist the entire child and family team in making sure we're meeting the needs of youth. Yes, question in the room.
So I actually do the mental health assessment in conjunction with CANS, and I was just wondering, because there has been a few examples where I've actually referred a child for a higher level of care based on that initial mental health assessment.
Yeah.
Would the wraparound coordinator then be expected to do another CANS after my?
Good question. Yeah. What we want to make sure we're doing at the community level is really communicating so that there's going to be one CANS for a youth. And so if the youth is involved in wraparound and in DHS custody, we're going to want to make sure that that team's coming together and they can use that one CANS for everyone's needs. So the child welfare worker would be using that in their work, and then maybe like your role, who might be sitting at that table, you'd be making sure that you're getting that information into ORCIDs just like you would in any other situation, but we wouldn't want to duplicate the
And the needs for the wraparound teams are going to be a little bit different, you know, whereas you might do the initial CANS and then work closely with the team's going to need to do them on a higher frequency. So it would be important for the team to communicate with you as well and say, hey, we're updating the CANS, what have you been seeing or what are you doing, you know, because what we're recommending in terms of best practices for wraparound is obviously if you've already done the CANS, they would work with you on the intake. Well, we're recommending intake quarterly, every 3 months, at discharge, and then at any life-changing events for our wraparound folks. So once you've done the initial one, it would be up to them and up to yourself to work together collaboratively to look at additional ones and to address them as needed.
So those are the recommended timelines. Those are not contracted. So in your role, in terms of what needs to go into ORCID, it would be the initial and then the annual rescreens, just like the current contract states. But in terms of, yeah, like Stephanie's saying, wraparound, we're putting out a recommendation on that happening more often. We're really tracking it.
Okay. So if there's a wraparound to it, it sounds like your job's going to be a little bit.
Oh, I don't really touch the kids after I refer them because they get assigned to therapists. I wouldn't actually be involved in the assigned therapist.
Our hope will be, yeah, that like you're saying, the wraparound team will be using your initial CAMs. Or it's possible, and I think we all need to explore this, and I'm open to hearing any ideas around this, is for youth in wraparound and DHS custody, if it's that time for that initial, within the first 60 days, CAMs, maybe that doesn't come to the individuals in your role, and your region's doing this very differently. Most regions don't have individuals like you that just fulfill this requirement. So it's more to talk about, because it's probably best for the child and family team to just go ahead and do this. I think we need to think about, but then how do we get that into ORCID so that child welfare has what they need? Does that make sense?
And I think as this moves towards ECANs, it's going to make it a lot easier, I would imagine, for everybody to utilize the same CANs and to make sure that it's up to date and that everybody's needs are being met.
So I just spoke about this. Oh, one question.
Shannon Brister, how will CAMs be used to support wraparound admission and or PRTS admissions? CASI level 4 to 6 to determine ICTS eligibility.
Okay, so wraparound eligibility criteria and the process through review committees will remain the same. CAMs won't determine yes or no on eligibility for wraparound. At this time, it will not be determining eligibility or medical necessity criteria for psychiatric residential treatment services, intensive community treatment services, intensive services, none of that. We're not there yet. That would be part of the 2017 rollout. Right now, we're using this as a communication and care planning tool within wraparound, and we're hopeful that those of you providing this for mental health providers and providing it for youth coming into DHS custody and care, that you're not just doing it because you need to fulfill that referral and get it into ORCID, that you'll start to look at this as how can this assist you in your work. Did that answer that?
Okay, Shannon, did that answer it?
Okay.
Can you hear me? I was
Yeah.
muted before. So okay. So I guess what if I understand correctly, then we'll still be required to do both. Right now, like if a youth were to be referred to yes, that agency requires a CAFE, and so the CAMS isn't going to somehow take over that. Is that accurate?
Eventually, we want CAMS to have a role in that. We don't have the eCAMS system, so there's nothing that's going to replace CAS and XP. There's not going to be a level of care determination tool. We want teams to look at the needs of the youth and family and apply the correct services to those needs or support.
Okay, and there's not going to be any review of, okay, you let somebody in the wraparound and they didn't have a CASI 4 through 6 type of thing.
Right, no CASI and XC required. And I see what you're saying. Okay, so some regions did put CASI and XC in their criteria for wraparound. I see what you're saying now. That was something that some CCOs decided to do that, but that was never something that Oregon Health Authority necessarily was hoping for. So because CASI and XC are coming out of the 2016 CCO contract, then we should be seeing that get pulled out of all the eligibility criteria.
All right, that helps, yeah, because that is in our contract. And so what I was just, that's kind of our, one of our determinations for eligibility in terms of wraparound. And so when you remove that, then we'll have to look at how we do say who does get in and who doesn't, or who is a good referral. So, all right, that's just a CCO thing.
Yep, and in addition, like I said before, we're not saying regions and CCOs cannot use it. We're just saying we're not requiring it. So there could be a CCO in a community that absolutely loves the CASI. Great, go ahead and use it. We're just pulling that back as a requirement because we're slowly trying to peel back some of all this tool and reporting requirement stuff we have out right now.
Thank you.
Melissa, are there any additional questions? Yes.
Okay, so again, Tom Projan at DHS Child Welfare does have the CANS unit at the state level where all the child welfare use of the CANS is determined, and DHS Child Welfare and Tom, if you have gotten back on yet, please chime in. But Joe within this unit at Child Welfare, he will continue to roll out training just for DHS Child Welfare workers and how they really want to increase how workers are using the CANS to provide care for use in child welfare custody and care.
Are you saying that the algorithm is different in determining the level between DHS and what you'll be doing at the wraparound? You said that DHS uses their own algorithm, but I just...
Yeah, and I'm not familiar with what they have set up at all. I know that it determines level of service need and decisions made for foster parents. But yeah, any of the systems that manage CANS outcome information, you can have algorithms set up in the background of those systems that can determine many things. Even different outcome measures or, yeah.
Okay.
So there's potential that within the mental health system, we might have something behind the scenes that's helping us do what CASI does for us today, let's say. Bringing attention to functional status, risk of harm, crisis items. Does that answer what you're asking?
Yeah, I think it's just a little confused that earlier question I had, if DHS was a different algorithm, how would you use that?
Right now, there won't be an algorithm for use in wraparound. It's just going to be used.
Yeah.
Oh, okay, just the information.
The information.
You should be paying attention.
So those 2s and 3s and actionable items, that team will be looking at.
Just be looking at individual items, not just the total. Okay, got it.
Yeah, we're not using, no total scores used within wraparound or even the mental health field right now.
And essentially with wraparound, the hope is really not only to utilize those needs that come up, those 2s and 3s for needs, but also to ensure that for wraparound teams are using those 0s and 1s and those centerpiece strengths. So that's really the hope with doing it in wraparound is those youth are typically very high needs and have a lot going on. Not only that, but it looks at the different types of needs and how to incorporate those into care planning as well. So it just gives a lot of direction for the care coordinators and a lot of support with decision making and planning. Angela, is there anything else you want to speak to, or Tom, in regards to the use of CANS and DHS currently?
I do not. Okay.
That's really all that we have for you guys today. We just wanted to go a little bit more in depth into the FAQ. And again, what I try to do is pull questions that I'm getting from around the sites and come up with relevant content for the CANS call-ins. But ultimately, this is your time to ask those questions and to get that support for any different area that you need. So we're here and we're available to you, and we want to give this to your time. And then again, for next month as well, if you're like, oh, there's this particular issue I'm seeing or this particular need that I have, feel free to let us know, and we'll be happy to address that in the call-in. Does anybody else have any questions or comments or anything that they would like to see us cover additionally that we haven't?
Like to compete with.
The question in the room was if I did any follow-up on, there was a good conversation last month in that if Oregon is trying to have one version of the CAMS to meet the needs within wraparound or across all of our systems, and now that wraparound is serving youth within the DD system, is that one CAMS going to meet their needs? Because there is a developmental disabilities version of the CAMS. So I brought that back to our CAMS steering committee at the state level and added it to the list of things that we need to consider, and probably it would be addressed when we are building the Oregon eCAMS system, because we'd be able to have the DD module available. So it's just going to be conversation within that development and how that works. Yeah, so it's on my plate now. Thank you.
Sorry.
Good. No, good.
I think it's better to have that on the front end when we're having all those conversations about the development of eCAMS and what that's going to look like, than to get those things way on the back end when everything's already built. So I think that's a great thing that you brought to our attention. I know when I worked with youth and wraparound, that was something we were seeing much more frequently. And it's essentially a different population with different needs, so it's important to make sure that their needs are clearly identified as well. So I think it was great that you brought that up.
There is one more complaint that I've heard amongst people that are from CAMS, is that there's such a wide range in the second CAMS age range. Has that ever been looked at, or has there ever been any breakdown more of ages, because it goes from 0 to 5, 6 to 20, which is a really interesting. When you're evaluating 6 to 7-year-olds, it's really kind of interesting, I guess.
Mark, do you know anything from Dr. Lyons on how that was determined? The age of 6 to 21.
Just because that it comes from the early childhood, earlier age, where they're looking a lot at a lot of developmental milestones. And some states do kind of state it differently. I've seen 0 to 4 and then 5 and up. And so it's something that I think the state, it would be a good conversation to continue to have with John. Selecting those items, each state gets to kind of choose what items they go with. So at one point somebody said, this is the items that we wanted to look at for 0 to 5 and 6 to 20 here in the state of Oregon. And if there are some items that are on that CAMS that aren't important, or they're not flowing well when it gets to the older kids that move into the 6 to 20, and there's not a good kind of connection with that, it's something that I think people should bring forward, and to make sure that we have an avenue to keep that conversation going about those specific items and those differences and those complaints and issues with it, because it gives the steering committee an opportunity to say, okay, look at this, we have a theme going on here, maybe we need to look at these particular items or how each of these is structured.
Yeah. So in terms of how the age range, that isn't an Oregon thing, that's across.
The nation,
So I could ask Dr. Lyons how that was determined and if they've ever considered having a smaller window of time.
Because even it just seems like, when I evaluate 6 and 7-year-olds that are in care, all the kids I see, they're developmentally neglected, and so they're just behind, and so that just, those pieces kind of go with the 6 to 20 screening, which is kind of doesn't serve those kids very well. We see a lot of kids at 6 or 7 or 8, so a lot of developmental needs.
I've seen states kind of tackle that and make exceptions, and then they utilize the earlier version for a child that's right there at that age range. So it's something I've just seen that done. I would defer to the state on that, about how that can be structured.
And I think absolutely you have a good point. I mean, that's a very broad spread, right? You have 0 to 5, and then you have 6 to 20. And then when you're looking at the needs of the transitional age youth that we have, I mean, there's extended foster care goes into 21, right? So the needs for the transitional age youth are also going to look very different than the needs of like a 8 or 9 or 10-year-old, So it's kind of making sure we encapsulate as much of that as possible.
And it's come up because there's also states that use the adult version of the CAN, and so when you go from the 6 to 20 to adult, and then there's been some exceptions with that too. So I think they just tried to set a standard for that. But of course, developmental, there's going to be some exceptions that are going to come up, but that might be appropriate.
And I know for me that the particular thing that I'm waiting for is the caregiver strengths and needs, and I know it's coming, so that's very exciting to me. I think that's going to really support the wraparound teams. I think that's really going to support mental health as well, because there's not too many assessment tools that necessarily look at that. And so it'll allow raters to really look at the caregivers as well and what's going on with the caregivers and where are their strengths and needs and how can we include that in our service planning. Does anybody have anything additional before we sign out? And again, this is your time, and we're here to support you. And hopefully, as you get going further and we do more trainings and we start implementing the CANs in different areas, these will be able to be that support that you guys need.
Something I should add is that, so for the January 2016 CCO contract, it does state that the CANs will be used within wraparound. That does not mean that on January 1st, we're going to be out looking at your wraparound programs and checking to see if you have everyone trained up on CANs and everyone certified and it's being used. This is going to take some transition time. So even if everyone's not certified and received the PSU training by that time, not a big deal. We're just going to begin infusing it within wraparound starting in January or maybe before if we can get you scheduled for a training. So that is not the expectation, and I know that many of you get concerned about contract language, and that's completely understandable, but from our perspective, it's really those of us, the site leads at the state level, that are really keeping track of the system. There's no other group of people at the Oregon Health Authority that's looking to see if CANs is being used, so it's going to be through a relationship and just making sure we're infusing it one step at a time.
So I have a question. So when is the CANs 101 training coming up?
Well, the first ones, there are 2 right now that are currently scheduled, but they're being scheduled by it's a little bit different from our 4-day trainings where we typically open them up to all the sites, only because everybody is at a specific place with it. We want to make sure that we're doing it region specific. So right now, the only 2 that are scheduled, there's one in, where's that region? Let's see. There's one scheduled out in Salem for the Marion County folks, I believe, and Polk County, and there's also one scheduled in Washington County for those folks. So I do have a couple more dates available for the end of the year or through November and December. So if that's something that you want to get scheduled, we can absolutely do that.
So, and the reason I'm asking is because currently the 4 wraparound care coordinators, and I am one of those, in Eastern Oregon, we've been using the CANs for about, I know I've been using it for almost a year now because I've been on a year. And the other 3 wrap care coordinators will be coming on, will have been on a year this coming for January timeframe. And so I think having that training scheduled in EOCCO would be great.
Yeah, and I'm definitely happy to do that. And that's something that we can definitely do. I know it's on I'm coming out to Eastern Oregon, I believe, soon to kind of see what the needs are going to be, because I have not, that's the one region I haven't really been out to yet. But that's something that feel free to send me an email or give me a call, and we can get that set up.
Okay, and I'll just CC my supervisor so that he's aware of that. He couldn't be on the call today. At least I don't think he is.
Should we work with Bruce Bailey on this?
Yeah, it's Bruce. Yeah.
Yeah, and I know
he's traveling today.
Yeah, and he's eager to get started and excited about it. So we'll get Stephanie and Bruce connected.
So then I have another question is, are we going to be recertifying the cans, doing the recertifying every year for the cans?
That's required anyway for CAN certification, so that's not a change.
No, I just wondered because it came up that I need to recertify, and I was like, ugh. I'm not looking forward to that.
Yeah, it is something that has to be done. That's through PRAID. That's not through us, but our trainings can support that. So if you're coming up for recertification and the other care coordinators are maybe going to get certified, then that would be a great time to look at doing CANS 101. And that's not to say that we're only, it's like, okay, we're just going to do one for Eastern Oregon and that's it. No, we're going to do whatever's needed. So I've really tried to make my training customizable to the sites and their needs. So if you decide next year too, oh, hey, we'd like a CANS 101 again, or we'd like a refresher, or we'd like this, absolutely, we'll discuss it for sure. I'm happy to do that.
No, that's great. And I think all of the other CANs, all of the other RAP care coordinators, they're coming up on their recertification as well in the next 3 months. So
Might be good timing then. Might be a little easier to pass those tests with, some more in-person training and assistance.
What was your name?
It's Christina Barnes.
Oh, hi, Christina.
Hi.
Okay, any more questions, comments, anything I should be thinking about as I'm working at the state level on the rollout?
All right, well, thank you, everybody. Hopefully these calls continue to grow and expand, and this one was recorded, so that's a new feature, so we'll see how that works out. But I look forward to seeing everybody next month, and it looks like we have a question.
So I missed the info about dates that are already on the books for training. Can I get that again? Karen Brooks.
Available dates, or dates that are available, or dates that are already scheduled?
Karen, can you hear us?
Scheduled. Can you hear me?
Yeah, we can hear you.
Okay. Yeah. Do you have something scheduled for the 101?
I do, only for 2 regions, however. One is coming up on the 10th, and it's for Marion and Polk County, and it's going to be out in Salem. And the other one is coming up in December. But I have some dates set aside that I could potentially get training scheduled. So Washington County is the other county, and that's going to be on December 15th. They also have requested a CANS 101.
So if
Where are you in
wanna,
that county? Salem would be convenient. Is that an option?
if you wouldn't mind, Karen, if you could connect with Stephanie, and we'll make sure, being these are region specific, so we're meeting the needs of the region. Let's get connected, and then we'll figure out if. You're right, that location would probably work best. So let's see if we can join wraparound programs.
Okay. I will do that.
All right.
What was that?
But I'll just do that and talk to Stephanie later.
Yeah, and then we can talk to Sydney Nestor and see what we can do.
Okay, thank you.
Any additional questions?
All right. Thank you, everybody. We appreciate your participation and look forward to seeing you next month.
Have a good Monday.
Thank you.
Bye.